I won't. Oops. Okay. Right. Okay, so tonight we're going to do module 15. Now, before we get going, does anybody want to ask anything? Dare I ask?
Oh, I was just interested. I've just read an email from Andrew saying that you're not teaching the classroom course. He is.
Yeah,
why is that?
It's not really convenient for me because I don't live anywhere here. And it would have meant I had to go and stay there, and it just doesn't really fit in with everything else I do. That's all. So
right, I just wondered.
Yeah.
Okay, cool.
Okay. So shall we get going? Yeah, everybody ready to go? Okay. So on to module 15. So I'm just going to share my screen with everybody. We will be doing a bit of practice tonight, but it's really easy practice tonight, just a bit of fun, really. Oh, come on. Oh, there, doing that. Right, play from start. Okay. Right, so we're going to talk a little bit about common therapeutic approaches. And I think what you're going to note as I'm talking about these is that we've dipped into all of these, and it's why you've got such a rounded approach, if you like, that you have as an Andrew Parr practitioner, or as you will all be soon. So just really looking at some of those areas, partly so you understand what they are. So, you know, if somebody's been working with a psychodynamic therapist, or they've been working with a CBT practitioner, that you understand what's, you know, those things are, what that means. And, you know, also some of you will already know that because you might have already worked in some of those areas. I haven't looked at counselling, I've kind of not looked at that, but it's just really to give you a bit of an idea about that. And as I said, you will see those parallels to what we do anyway, and it just gives you a better understanding. Also going to briefly look at psychosis, what that is, what to look for. And then finally, we're just going to have a bit of fun with some confusion inductions, which is really made for people that perhaps might be a bit resistant, or struggle to relax, or really try and sabotage everything you're trying to do. So sometimes they can be quite a useful tool. I don't think I've personally ever used one. I remember Andrew doing one on us when I did my training, but it's just another little tool for the toolbox should everything else be failing in one way or another with somebody, or you really feel you've got somebody who is just going to be so resistant. They can be something that can be quite good to do. So we're just going to have a bit of fun with that at the end of the session. So moving on to our final module now. I just can't believe how quickly we seem to have got here. I hope you feel the same, otherwise that means you'll have been bored, but it does seem to have gone very, very quickly. But by the end of this module, hopefully you're going to have a better understanding of some of the therapeutic approaches that you will actually see or would come across in mainstream psychology that your clients might have had. You might have even had some of these yourself over the years. And obviously, if you want to know any more about any of those, then it's a good idea to read up a bit more on them, find out a bit more sort of history about them. So I'm only really giving you a bite-sized chunk on any of these things. It's really just putting them into context a little. To have an understanding of psychosis and how to identify it in a client and what to do with it if you do. The confusion induction, which I said we're going to sort of do at the end of the session. And then from next week, possibly, but certainly you're going to do some of this with Andrew, is looking at sales psychology, and in a way that will help you to launch your own business. So you can really start thinking about how you sort of start to perhaps maybe pigeonhole yourself into a certain area and specialize, but also looking at different things that you can do to start to get going, set up your business, and promote yourself. So Andrew's going to give you lots on that. I might give you a little bit of input on that next week as well, from my point of view, what I've done. Obviously, Andrew's by far the successful one here, so we really want to hear what Andrew's done. So, but there's also, in terms of the sales psychology and tips for marketing, there's a really good session from James Taylor on the members area that he talked about some of the things that he does as well. So it's really good to hear what other people have done, because not everybody wants to be busy with loads of clients every week. You might only have in your head that you want a few. So it depends what you're actually trying to achieve. So So moving on to today. So looking at some of these common therapeutic approaches, starting with psychodynamic therapy. Now, I remember when I qualified with Andrew, and he said, you can actually call yourself a psychodynamic therapist. We are doing a lot of these things as part of what we do. So what psychodynamic therapy really is, it's that sort of very much in-depth psychology, but it's all very much linked with what we do. You know, if you see the model here of the iceberg, very much like the pyramid, isn't it? Very much similar to the pyramid model. I think I might have actually shown you something similar to this when we looked at the pyramid model, to just look at what that is. But obviously that really starts with Freud, and it's looking at the awareness being above the water there, and the subconscious being below the surface. And of course, Freud was the first one in terms of psychology that we tend to think of in relation to dealing with that, and actually looking at the unconscious content of our psyche and so on. So a lot of the things and techniques that somebody that would be involved in this would be things like sort of a lot of the things, again, that will be very familiar to you, sort of free association, word association. Obviously, we do a lot of things like following the feeling, but all of this kind of comes out of the same sort of area, really. So if you want to know a little bit more about the sort of the history of that, I mean, some of you will have done some of this in your initial essay, I would have thought, when you looked at the history of hypnosis, but this is just one area. But as you can see, that does look at what's unconsciously going on as well, in the same way as we do. Now, something you're hearing quite a lot about these days, particularly when we come to CBT, because CBT is a combination of behavioural psychology and cognitive psychology, or sort of cognitive therapy, whatever you want to call it, really. And that's really where the two come together. So we have behavioural psychology, and that's when you think about things like, I'm sure you've all heard of Pavlov's dogs, and you know, where we're looking at classical conditioning as being a very, very sort of foundational part of behavioural psychology. And the basic idea here really is that you try and change your life, or change aspects of your life, by changing your behaviour and then reinforcing that with new behaviour, very much like in the case of Pavlov's dogs. And if you don't know about that particular sort of experiment which kind of got all of that going, I recommend have a read up on that, because it links into things like CBT, because obviously the two of these areas come together. So quite a few different theorists, that can be traced back, mainly sort of mid-20th century. One of the big names that you'll come across probably, Skinner is quite a big one there, and Beck are the two main ones that you'll probably hear as being key pioneers in this field. And it was Beck and Ellis as well that pioneered the cognitive behavioural therapy, which we'll talk about a bit in a moment. So this is, you know, this sort of thing started to arise mid-19th century, really. You started to see that sort of, sorry, not mid-19th century, I'm thinking 1900s, 20th century, where we actually started to explore other ways of looking at people's behaviour, and being able to help people psychologically. Then you have your cognitive therapy. Cognitive psychology, as you'd expect, is all about the mind, you know, how we think, how we remember things, how we make decisions, how we see the world and perceive the world. It's all about how we kind of take information in, how we process that, and what we do with it. So it's a very sort of intellectual approach, and it can, you know, and again, you're going to recognize an awful lot of what is going on here in terms of the way we deal with things, in the way that you've been trained as a hypnotherapist, that we are looking at language, problem solving, how, again, perception, changing perspectives, changing perception of things. So all of this comes into what we do. Now there's a sort of a quotation here by Beck, who, again, 1995 this was, says that cognitive therapy is a focused form of psychotherapy based on a model of stipulating that psychiatric disorders involve dysfunctional thinking that have arisen from both biological and psychological influences, and individuals' emotional, behavioural and physiological reactions are influenced by the way they structure their environment. Quite a mouthful there, but kind of gives you just a bit of a sort of a potted idea of what cognitive therapy is about. But basically it's the sort of very intellectual aspect of it, really looking at what we do with all that information, how we see things, how we store it, how we process it. And then we come to cognitive behavioural therapy. Now, anybody that's had any problems, if they've gone to the doctors with depression these days or anxiety or anything, seems to immediately get referred to a CBT practitioner. And they do tend to do it in courses these days, which from my feedback from clients don't tend to go down too well. But at certain, depending on what your issue is and what you're trying to resolve and at what stage you are in that issue, if you like, whether you're coming out of it or whether it's really at a very bad place, CBT, as it's mainly referred to, can be really, really helpful. It's a form of talking therapy, but it combines those two aspects, the sort of how we behave and how we think. So the classic thing that we all talk about is think, feel, and how we behave, and that is the thing that you'll always hear in relation to CBT. So very much focusing on how you think about your life, might be your beliefs as well, so digging into those, looking at how you're thinking about those things, and feeding into how you behave and deal with emotional things that are going on in your life. It helps and can be very helpful to help you change negative thinking patterns, and also, again, obviously behaviour. And obviously we all know, in terms of what we've done here as well, that this in turn can change how you feel. You'll tend to find most people that are working in CBT will work on the basis of giving you homework. You'll get lots of little sort of series of things that, you tend to get a course of CBT. That tends to be how it works these days. People get signed up for a 6 to 12 week course in CBT, and they'll work through a series of kind of almost tasks that you work through. And as I said, it can be very, very helpful for some people to kind of start to change how they think, feel and behave. It's a very conscious process, but you again will probably notice that a lot of the things we're talking about here are all things that we dig into as well, but we're quite often dealing with that in a much more sort of subconscious way. Not always, obviously, sometimes we're, this comes out in the chat. But yeah, very, very much something that you will find that a lot of your clients might come to you and will have been through this. They've either have tried it or they might have just been referred to it as well. But again, it's all about thoughts, feelings and behaviour. So it's bringing all of those things together. It was never designed as a treatment to be completely holistic. And I think that's part of the problem with the way it's recommended sometimes. It is part of a process of getting somebody back on the right track again in terms of negative behaviour, negative thoughts and so on. But it does tend to get recommended as a bit of a cure-all, very much holistic treatments. And it was never really developed that way. It was just part of, sort of that process. Okay, now we come on to humanistic psychology, again developed in the sort of mid-century, 1950s, I think it was, all very much about stressing the importance of personal choice and responsibility for your own behaviour and your own actions. And it develops and evolves out of psychoanalysis and behaviourism, and which were obviously the key, the main ones before this that were really dominating things. So where psychoanalysis, as in Freudian psychoanalysis, was more focused on understanding unconscious behaviour and unconscious sort of feelings and motivations, behaviourism much more about the conditioning processes and so on. But humanist sort of thinkers and theorists believed that these two sort of processes, psychoanalysis and behaviourism, were a little bit too negative, and really only focusing on the negatives. and not necessarily taking into account the role of your own decisions, your own personal choice. So it's much more focused on people's potential to change, to sort of recognize themselves, to grow, and self-actualization. Now, I don't know if any of you that have been involved in marketing in any way will have come across this lovely model here, Maslow's hierarchy of needs, which tends to get bandied around in advertising and so on. But it talks about our basic needs at the very basic level. So sort of obviously breathing, eating, the need for water, sex, sleep, all the things that we need to do. And then we're going up the levels. So you go to safety, which will be security of your body, perhaps having a job, and resources, money, health, that sort of thing. Then you get to love and belonging. This is very familiar to core beliefs, isn't it, really, when you look at it? Family and intimacy. And then you get to self-esteem, confidence, achievement, respect of others, respect by others, and then self-actualization, which is that sort of bigger thing, that sort of morality, creativity, kind of identity, really, lack of prejudice, problem solving, all of these different things. And when this is used in relation to marketing, that self-actualization is what you're getting when you buy into that certain brand. You know, you don't need it. It's all about your image, if you like, and your identity. So Maslow's hierarchy of needs, he was one of the theorists of this particular form of psychology, developed this sort of pyramid, which, you know, it refers to that. There's other forms of therapy that fall under this. One that you will have come across with Andrew is Gestalt therapy. Gestalt meaning the whole. The common sort of statement you hear is the whole is more than the sum of its parts. So it's a very holistic, very person-centered form of psychotherapy. So it's very much about stressing your own individual responsibility and awareness of what your psychological needs are and what your physical needs might be. So, you know, and it's looking at not just an environmental approach or what, you know, what happened to you when you were younger or before you were born or whatever it was. It's looking at the whole. It's bringing lots of things in. And there's lots of other areas that come off things like Gestalt theory, like field theory and all that sort of thing. So there's lots of different things you could look into, again, if you're interested in that. And Gestalt therapy, I think that's where parts comes from initially. So I think they call it empty chair in Gestalt therapy. So a lot of that's come from there. And you'll probably, if any of you've got a designy background, will have come across Gestalt as it's like a form of theory for visual communication as well. That's where I first discovered it, actually, but it actually is psychological theory. Means patterns, how we look for patterns. So the nearest sort of definition of the word Gestalt, because it's a German word, is Gestalten, which means pattern. So how our brain naturally looks for finding patterns, looking to make something whole. Okay, so that's where it covers the whole thing. Okay. And then one that is probably very much more recent, people like Maslow were involved in this as well, and somebody called Viktor Frankl. This is all much more, it's transpersonal psychology. So it's that field of thought that's much more centered around the spiritual side of human life. So it's not religious, it's not necessarily airy-fairy, but it's much more a transpersonal approach. This came about in the 1960s, and it's just looking at methods and theories that examine the spiritual side of the world. Aspects of that might be body awareness, like mindfulness and meditation, that sort of thing, journal writing, breath work, inner child even, guided visualization, a lot of yoga. All of these things kind of come into transpersonal therapy, and it's definitely something that's on the rise at the moment, and loosely translates as beyond the person or beyond the self. So it's kind of getting beyond the ego, if you like. So there's a sort of a few different types of sort of areas of psychology that you might come across, and you might find that as I said, you might find your clients have already ventured into this area in some way, or they might be doing that at the same time as seeing you. But I'm sure you'll see that with each of those, there's quite a strong crossover with a lot of the things that we're already doing. We're sort of, Andrew's sort of gone in there and he's picked the best of everything to sort of help us do what we do and help to bring about that transformation. So here's just a final sort of diagram there. So just looking at, you've got your original psychoanalysis back in the 1880s with Freud, initially working with the subconscious and hysterical patients. Then you've got your psychodynamic and psychoanalysis. And you've got, again, Freud and other names like Adler, Ferenczi, Abraham, and so on, all focusing on the dynamics between the conscious and the unconscious again, and different parts of the psyche and how the external world affects things. So it's really looking again at quite a whole sort of way of looking at things. You've then got the behavioural, so less focus on just the past. It might be the past comes into it, but it's really about trying to bring about behavioural changes by thoughts, feelings, and behaviour. So that cognitive aspect comes into that as well. And then you've got the more recent humanistic approach. And when I say recent, it's not that recent, it's sort of mid last century. But you've got people looking at things that are much more focused on the individual and the individual taking responsibility. And that sort of, you've got much more person-centered, if you like. So things like Gestalt, and it's actually got here psychodrama. I don't know if some of you have come across things like family constellations, drama therapy, writing therapy, all of these different things could come into this. Okay, so just a bit of an overview there on some of those things. So has anybody got any questions before I move on? No? Okay. So as I say, you don't need to know about this in massive depth. I'm pretty certain as part of your assignments, you will be required to look into them in a bit more depth anyway. But you don't need to know everything about them. You just need to be aware of the basics so that you've got some idea, if somebody's been to see one of these people, that you've got some idea what approach they may have taken and how that would work. And also to understand where a lot of that feeds into what you are doing as well. Okay, just a quick sort of look at psychosis, because obviously this can be something that you could be dealing with. Somebody could come to you and you could have to sort of perhaps refer and maybe not be able to work with some people. So you will come across it. I don't think I've ever had anybody that I've had to send away because of not being able to deal with them. But when we think about psychosis, it's a feature of mental illness. Now, a lot of the things we deal with will be sometimes a feature of mental illness, but this can be a little bit more serious. So it can be sort of characterized by much more radical sort of things such as personality changes, not being able to function in the workplace, in family life, and so on, and sometimes having a very, very sort of distorted sense of what reality is. So this can be one of the things that you'll come across. So sometimes they just might not be able to distinguish between what's real in the real world and what's in their head, if you like. Sometimes might have hallucinations. They can be delusional, and obviously this can all be to a different level. Some people can be very seriously psychotic, some people on a much lower level. But quite often their behaviour might be inappropriate, they might communicate inappropriate, they might even be incoherent. And psychosis itself can appear in a number of different sort of disorders. So, there isn't just one thing that we say is about psychosis. Things like schizophrenia, schizophreniform disorder, schizoaffective disorder, delusional disorder, and various different things that can actually come into this category. And the causes can be different as well. Sometimes they are purely sort of biological stroke physiological, sometimes they're psychological. It really does depend, and sometimes, and we'll look at them as a few examples, sometimes these can be temporary. So you can actually have something called sort of like a brief psychosis due to circumstances. So it's not always forever, and it's not always genetic. And we know that the jury's out on genetics anyway, isn't it, in terms of what we know about epigenetics anyway. So as I said, biological factors can be a factor. So we can have sort of genetic abnormalities, but also sometimes it comes out of substance abuse. But though sometimes there's an argument to say that if there is that sort of propensity, if you like, to have psychosis in any way, sometimes substance abuse will make that more likely to happen. So, whether that's alcohol, whether it's drugs or whatever. And I think back in 2004, it was reported that cannabis was actually a risk factor with people that might have been likely to get psychosis, and it could actually cause the onset. And I actually have a family member, not on my side of the family actually, where this did actually happen. And he's schizophrenic, and has been since he took cannabis, and it was believed to be that it was possibly going to happen at some point, or something was going to trigger it, but it did trigger it. So
same here, Debbie. I've had that experience as well with a close friend, and
really?
Actually I've seen it happen more than once actually. Yeah,
a lot of people don't believe it, do they? And I think
I've seen it with my own eyes, and it ended very badly, unfortunately. So yeah, it's
bad.
if you've got a anything that you wouldn't even know about, any propensity to it, it can be incredibly dangerous. Yeah.
Thank you for that, Nicola. I'm sorry that you've had that experience, but and I think it is, like you say, because cannabis on the whole can be quite harmless, that people don't necessarily understand the risk factors there. And I think if you've got anything, even people with things like bipolar, quite often it's recommended they don't drink, they don't do these things, because it could bring on an onset of it. So but thank you for that. Another thing that can be a factor is, or has been found quite recently, is migration. So we've got a lot of immigrants coming over, and there's been an increasing rate of things like schizophrenia and other psychotic disorders as well. And Black immigrants from Africa and the Caribbean also being quite vulnerable. So I guess because migration brings on an onset of lots of other things, doesn't it? That sort of being in a place where you don't feel like maybe you fit in initially, perhaps you've lost family. In some cases, some of these refugees will have lost everything and would have seen terrible things. So there's going to be things that are going to come out of that. So, you can understand how this might lead to that. So that can be another factor. So, oops, sorry, I didn't mean to do that. Come back. Oh, can't go back. Okay, so just some of the areas of psychosis. So I said we've got schizophrenia, schizophreniform disorder, schizoaffective disorder. All of these can be, sort of linked to psychosis, and sometimes it's considered that there is abnormalities in the way the brain has been structured, and possibly a sort of chemical imbalance as well. Some cases genetic links, but as I said, I think a lot of this is in question these days, so this is just information that's out there now. It can also be caused by stress, sort of family problems, all sorts of things that can cause it, anxiety. So there's lots of different areas of psychosis. Something that comes up is delusional disorder. Again, this is something that's inconclusive as to kind of how that comes about, what the cause is. But again, potential causes can be sort of neurological abnormalities, changes in the brain chemistry again, hereditary can be hereditary, so sort of a genetic thing. And there's also studies to say that delusions are sometimes generated by abnormalities in the limbic system, which is obviously all sort of relating to regulating the emotions and so on. But again, based on a lot of the new stuff that we're hearing now and around things like epigenetics, a lot of this stuff could be put into question, couldn't it? That how that actually comes about. I mentioned earlier on about brief psychotic disorder. This is where something quite major's happened. So a trauma or a major stress can bring about short-term psychosis. It can be less than a month. And it could be something very major, like death of a major family member, a natural disaster. So these can actually bring about a sort of a brief psychotic disorder, even though there may be no history there at all. So that sometimes can happen.
Debbie?
Yes.
Sometimes that might be known as first episode psychosis.
Ah, right. Okay. Thank you for that. So first episode psychosis, have you come across that?
Yes.
Right. Okay. Can you tell us any more about that? Anything that you've sort of experienced from that?
Well, it was my boy's father.
Really? Right.
Yeah. He had first episode psychosis.
Gosh.
And there was extreme paranoia, and ultimately it ended with him attempting to take his own life.
Gosh, that's really... And how long did that last? Was that a very short episode?
It was going on for about 2 weeks before his attempt to suicide, and it was another 6 weeks at least before he was stable mentally and out of the crisis team's daily visits.
Right. Gosh, I'm sorry you had to deal with that. That must have been really hard.
Yeah. Well,
thank you for sharing that. It's actually, I mean, it's helpful to know when people have known of these things, so that it kind of clarifies it even more. But thank you for that, Rachel. Okay. Another one here, psychotic disorder due to a general medical condition. So it can be triggered by something else, sometimes maybe a neurological thing. So, for example, if somebody's got things like epilepsy, or metabolic conditions, for example, porphyria. That's the one I think King George had, wasn't it? And I think Victoria's family, and possibly Princess Margaret as well, I think. So various different sort of physical conditions can sometimes trigger a psychotic disorder as well. So lots of different circumstances in which that can happen. So one of the ones I mentioned earlier was substance-induced psychotic disorder, and it can be a side effect of using certain drugs. And obviously we talked about the fact that even taking cannabis could trigger something, but a lot of obviously there's a lot of drug use out there and has been for many years now, but some of the sort of general recreational drugs can also trigger this. So, things like cocaine, as we said before, marijuana, alcohol can cause a psychotic reaction, either while it's being used or as part of withdrawing, if it's been quite a major thing. And some prescription medications can even cause a disorder here as well. And also carbon monoxide has also been reported to actually induce a psychotic disorder at times. So it's quite scary that there's so many different ways in which this can happen. And then finally, shared psychotic disorder. It'd be interesting to know if anybody's ever come across this with anybody that they know, but the idea that it's psychosis by association, and it's not that common, although I wonder if it's probably more common than maybe we know, but it's when 2 or more people are involved, but they have to be very emotionally close, and apparently it differentiates from the east to west, that in the West we tend to develop more between, say, 2 sisters or a husband and wife, but in places like Japan it might be more likely to be a parent and a son or a daughter, and very occasionally it can involve an entire nuclear family. So that's quite an interesting one. Has anybody come across that before, or know of any situations where they think that they may have come across that themselves?
Maybe it's called folie à deux.
Yes, folie à deux. Yes.
Many times.
I can pronounce French. I was. So yes, it is known as folie à deux, but also psychosis by association. So okay. Okay, so just some of the things that you might want to look out for, should you be, you know, and please don't let this worry you. I can assure you I've not come across this myself, and it doesn't mean you won't in your clients. And sometimes you can pick it up on, I have picked it up on the phone in people before, where I've felt that actually they needed referring somewhere else, but I haven't actually had anybody sat in front of me where I've had to refer. Because I know when I first found out about all these different things that you might need to look out for, it felt a little bit scary. So please don't let it worry you, because you know you're not necessarily going to come across this a lot. But some of the symptoms to look out for: delusions, and usually quite bizarre, but sometimes can be almost plausible, but still not true. Also things like paranoia come along with that as well, hallucinations, and you'll find that people that actually have psychosis might actually sort of, all the senses will sense things that aren't there. So they might see, hear, smell, taste, or feel things that really are just not there. Mostly it tends to be they hear things rather than see, but it can be both ways. But they really, really do believe what they are seeing, feeling, tasting, whatever is actually happening. And in some cases, I said, it can involve all the senses. You might find they come across as very incoherent, with lots of sort of speech all over the place, very fast speaking. And I'm thinking, am I speaking too fast now? But sort of rambling a lot as well. And then very, very disorganized, and possibly behaving very, very inappropriately, engaging in sort of things like, you know, as I said, might be talking too quickly, they might be moving their hands too quickly, they might be sort of just very, very unpredictable. And the chances are, if you're in the company of somebody like this, you're going to feel quite uncomfortable. You're going to pick up on something not being quite right. So they're just some of the things that you could look out for. In terms of diagnosis of psychosis, generally they need to go through a full physical examination. Now, again, this isn't something that you're necessarily going to be involved in. Some of you might already have been involved in this in your previous careers, but as part of what you do as a hypnotherapist, you're not necessarily going to have to do that, but these are some of the things that they might need to do. If somebody is suspected of schizophrenia, for example, they will need an assessment with a psychiatrist, perhaps need medication, and other interventions that perhaps we would not get involved in. So, you know, to evaluate their mental status, we're not, you know, we don't diagnose. That's not what you're trained to do. Some of you might have those skills as well, again, from other careers. So I appreciate that might be different. But in terms of your training here, you're not, you know, you're not evaluating in this way. You know, that needs to be done by the medical profession. Other symptoms and behaviours could be sort of signs of psychosis, where family and friends might have to take them to emergency, and if they are a danger to themselves or a danger to anybody else, if they are sort of that psychotic, they can be legally hospitalised or sectioned without their will, if, you know, if they're violent or they're threatening to hurt themselves or anybody else. So that's something that can happen there. Or even if it's very, very evident that they are not caring for themselves. You know, for example, they're not eating properly, they're not dressing themselves, cleaning themselves, that sort of thing. Again, could be a reason why they might be sort of hospitalised. But again, this isn't something you'd necessarily need to get directly involved with, just some things that, you know, are good to be aware of. Okay, so as you know, psychosis is often symptomatic of schizophrenia and other psychiatric disorders, so would be treated and diagnosed by a psychologist or a psychiatrist, not by us. Okay, unless you have that qualification yourself as in addition to this. So, you know, quite often they would need to be on a course of medication and certain types of therapy that they would be sort of doing. Yeah, just as I said, a lot of this is all about awareness more than anything else, just in case you do come into a situation where perhaps somebody needs to either be referred or you detect that perhaps it's a little bit more than you can handle. So really just helpful for you to know. Okay, so any questions about that before we move on? Nope. Okay, right, so moving completely away from that, just really giving that information. Obviously, you've got that information again in your handbook, and I really would recommend that you read into some of those areas a little bit more, all of the things that I've spoken about today, because it's really just a brief overview of those areas, the types of therapies, the types of psychosis, that sort of thing. Just read into that and get a little bit more of an understanding it for yourself, so you've got a more in-depth idea there. So I mentioned briefly at the beginning that we were going to look at confusion inductions, and you'll notice on, I'm not quite sure what page it is, but after you've gone past the stuff we've just covered, that there will be a script for confusion inductions. And what we're actually, you tend to use a confusion induction if you've got somebody who you're perhaps struggling with. And the idea is that they kind of get so confused trying to work it out that they'll actually sort of tend to shut down and go inside instead. So very, very helpful if you've got somebody who is possibly very, highly analytical, trying to be as uncooperative as possible, really, in relation to the sort of hypnosis aspect of a session, or somebody that's very, very controlling, somebody that really, really has to be in control of everything, including themselves. So it can be useful there, because it kind of, just as I said, it sort of jumbles that conscious mind a little, and stops them sort of planning, analysing, and sort of being so aware. So it can be quite good for that. You will get the odd client who will be saying, no, I don't think it's, it's not going to work for me. I don't think I can be hypnotized. Or you might get the client that says, I'm really scared, I can't do it. I can't stop thinking. I'm always planning. I'm always sort of thinking about what the next thing is. So this might be the sort of thing that could be really quite powerful for those kind of people. However, not a good idea if you've got somebody who's already quite confused, or suicidal, possibly grief, or paranoid in any way. So they're all the areas that not a good idea. Some of you might really like this and it might really work well for you. Some of you might absolutely hate it. It's just one of those kind of love-hate things, really. But what I'm going to propose is tonight that you all take at least one go of just reading that confusion induction to each other and just getting a feel of what it's like from the angle of obviously delivering it, but also receiving it as a client, and talk about what that's like for you in terms of that. So that's what we are going to do tonight. Just come back and stop sharing. Okay, and see you all again. Okay, now I think everybody, but I think Angie's not well tonight, so Angie definitely needs to be an observer, Heather. She won't be able to do that, but is everybody okay for doing that tonight? Yeah. Okay, be interesting to see what you make of the confusion inductions. I think if there's no more questions, it's literally just follow the script and just go with it, really. Anybody got any questions? No? Okay. Heather, anything else you want to add to that? Everybody's really quiet tonight. It's okay, right, okay. Well, if you put us into our